Hello everyone, this is Dr. Srinivas Kishore, Director of ENT at AIG Hospitals, Hyderabad. Today, I would like to discuss with you a case scenario primarily describing the very essence of managing obstructive sleep apnea. As we all know, obstructive sleep apnea is a condition caused by obstruction at multiple levels, and there are various mechanisms that are involved in resulting whatever results in this kind of a collapse. Now, over the years, we have learned that obstructive sleep apnea cannot be treated by a single specialty. It's truly a multidisciplinary approach that basically helps us and our patients to come out of this or come out with treatment options for these patients. Here, I would like to discuss a case with you, which we have successfully managed with this kind of multidisciplinary management. So, I present to you Mrs. L, aged 45 years, with symptoms of snoring, excessive daytime sleepiness, dryness in the throat when she wakes up, and also sometimes wakes up in the middle of the night with a choked, parched, dry throat. When she wakes up in the morning, she's also feels excessively tired. On examination, as you can see, she is about 5.4 and weighs about 70 kilos. So that kind of weight for that kind of a height would clearly put her in the overweight category. From a skeletal standpoint, she looks fairly okay, except for the fact that she has a short neck, a very squarish kind of face, and does not have very typical class 2 or a class 3 kind of a facial profile to put her into the skeletal basket right away. But the examination actually throws in more light. She does have a crowded nose because of a deviated nasal septum, turbinate hypertrophy. There was no valve involvement, but on examination of the oral cavity, there was a high arched palate, what we also known as an ogival palate. The Friedman tongue position was 2B, and the tonsils were Brodsky 2. So here is a picture of her intraoral exam, and you can see the Friedman tongue position 2B. Here is the patient's flexible pharyngoscopy. This is done in the outpatient clinic. As you can see that there are lingual tonsils, fairly laxed palate. Other than that, you can also see a lot of mucosal redundancy. Other than these two very classical positive findings, there are no clear-cut obstructions that are there in the upper airway. Going down further into managing, we've done a sleep study. We have done a level 3 sleep study because clinically she looked like a classical case of obstructive sleep apnea. Would I have done a level 2 sleep study for her? Should I be doing a level 2 sleep study for her? That requires another talk and another discussion. But to just take you through the level 3 sleep study, Her respiratory event index was about 37.7, of which the apneic index was 2, but the hypopneic index was about 29. The oxygen, the ODI, is about 40.1. That means this patient was having about 40 desaturations, wherein the oxygen saturation was falling by 4% every hour, 40 times. The average saturation was high up at about 92, but the lowest desaturation was 63. The minimum pulse was 63 and the maximum pulse was 120. What is more interesting is the desaturations below 90%, about 107 minutes of desaturations. Below the time spent below 90% was 107. So as the patient was in the overweight category, and she was clearly not having classical obstructions in the upper airway, which could yield us good results. And since she had severe sleep apnea, the obvious choice was to put her on a CPAP with weight reduction put her into strict weight reduction regimes. Now, 6 months on, the patient come back with a fairly decent PAP compliance report. What was interesting there was she was requiring a very high pressure of about 14 centimeters of water pressure. Now, we know from literature that CPAP pressures above 8 centimeters of water pressure is indicative of fairly collapsible airway, and she is requiring a lot of pressure to open up that particular airway. What was also interesting was, in spite of a good PAP compliance, she had excessive daytime sleepiness and fatigue. Now, excessive daytime sleepiness and fatigue are very important things, especially when it comes to treatment of obstructive sleep apnea. A lot of times we think that hypoxia causes excessive daytime sleepiness, but that is not true. That is not true because a lot of patients, if you take patients with COPD or some chronic lung disorders, these patients do have hypoxia, but all of them don't exhibit excessive daytime sleepiness. Now, there could be various reasons for persistent excessive daytime sleepiness, ranging right from poor sleep hygiene to some kind of a sleep routine that may be causing excessive daytime sleepiness. So once you rule out these things, the next thing that you should go out to find out in patients who are PAP compliant as to why they are having excessive daytime sleepiness is hormonal issues, especially at this particular age group, having hyperthyroidism or perimenopausal symptoms. The other things that you should also look out for is try making them answer the questionnaires and try them and make them do the MSLT test, which would actually tell us whether the excessive daytime sleepiness is actually there. And if it is there, we will know how much it is there. Then we need to actually go back and do a level 2 study to see if the excessive daytime sleepiness is being caused by things like restless leg syndrome or pediatric limb movements. So the other thing that we need to really again look at is to clearly differentiate between fatigue and excessive daytime sleepiness, which are two different conditions. So with that kind of a background, of course, because this is not a presentation about excessive daytime sleepiness nor fatigue, we move on further. So at this point, since the patient was clearly not getting benefited, we put this case for our sleep board. At our institute, we normally keep complex cases to the sleep board, which basically is a conglomeration of specialists from ENT, oromaxillofacial, orthodontics, and pulmonology. So we actually discussed this case and we came out to a particular conclusion. And the conclusion was to do a drug-induced sleep endoscopy to understand the behavior of the upper airway during this patient's sleep. Scoring to help us decipher the depth of sedation. Here you can see two prominent salpingopharyngeal folds touching the posterior pharyngeal wall, but the obstruction at the level of the velum is about more than 75%, which clearly gives this a grade 2 in the VOTE classification. The salpingopharyngeal folds, which extend down as the palatopharyngeal folds, airway obstruction, as we can see. Going one notch down, we are able to see the obstruction at the level of the oropharynx. We are able to see a lateral collapse, a lateral complete collapse. That means O2 at the level of the oropharynx. What is very clear at the level of the base of the tongue is the lingual tonsils, which we could also see at the flexible laryngopharynx. Now, when you do drug-induced sleep endoscopy, you need to do this at least for a decent time, at least about 10 to 15 minutes. Now, there are other uh, methods, drugs that can be used, that is dexmedetomidine, midazolam, etc. Now, the problem with dexmedetomidine is even though it gives us very good stability of the upper airway, the problem with dexmedetomidine is it has not been shown to give us the adequate behavior of the upper airway at the lowest saturation that the sleep study recorded. Also, it cannot be used in patients who have any kind of a cardiac. Here you can see that we have done the sleep endoscopy for a decent, and we have actually testing the jaw thrust and see if the airway actually. There can be a lot of can be done in these interventions, as we call as interventional dice. When we do this, we can get an idea as to how to help change the behavior of the upper airway. Bring us an idea if other kinds of modalities other than PAP in the patients. So once we saw the dyes, the sleep board decided that this patient has transverse deficiency of the maxilla, as we very clearly knew on with a high arched palate. From an ENT standpoint, decided to do a tonsillectomy and a Barb repositioning pharyngoplasty and a lingual tonsillectomy. So, with this plan in mind, we started to do a Barb repositioning pharyngoplasty, which you will see now. Uh, you can see the markings here. And at first, we are doing a with a one, the ones. The active electrode saying when we were using the legend wands, because the legend wands grasping, and we have excised quite a bit. Machine is working in a high setting. You can actually see the paratonsillar vein So one interesting thing that you can see here is extra third. We clearly shift to so on the rope actually works as this sort of works as a um, we are opening it now. The ventral aspect of the halo bond is going to use the bipolar, the coag keeps being done by the ventral aspect of the bond. So once we should be very careful to preserve the mucosa as much as possible, you're able to see here, and you're also able to see the spatula part of the body, and you can also see the directions of the palatopharynx muscle. And we've now slowly taken it off, and very clearly you can see the little bit of tonsil tissue here. Let me look now. This technique has helped me a lot to prevent secondary issues. Kind of a tonsillectomy has helped to reduce secondary hemorrhages. Now, the next step of this is to remove the supratonsillar fat pad. As you can see, um, we're using the coblation again, the spatula, to expose the supratonsillar fat tube. Very important that we cut off the medially arching fibers of the palatopharyngeus muscle. You can either take it off or you can coagulate it. Now you're able to see beautifully the supratonsillar fat bag. This is very essential to create an area there so that the posterior pillar can be relocated, and that sort of gives us the boxed picture at the end of a Barb relocation. Now, once that step has been also done, we will have to also cut the Every time there is a suture, there is not only the palate. So in the opposite side, we can go ahead and you can be happening here as well. Now, if you think that the uvula can do a nice comes back the same way that we went in. Right? You can see that how it is come into a little bit of ropivacaine would always help in such case. Now, you can also do the same thing. We're using an exoscope to do the procedure. This is the same procedure, but earlier we were using a microscope and now we're using an exoscope. Um, this is, of course, a different patients. The reason why I was showing you this is the clarity from an exoscope is also pretty good. But the steps are all the same. The procedure is the same. Now, a few words about the pterygomandibular RFA. Um, it's it's a condensation, as you can see. The This is the pterygomandibular raphe. This is the superior constrictor muscle which goes round, and this is the parotid gland. This is the ramus of the mandible. This is the masseter muscle, as you can see. Here are some tips for Barb relocation pharyngoplasty. The surgeon's visual angle should be different during tonsillectomy and BRP because in tonsil you're further down. Infiltrate the area with xylocaine and adrenaline to get a better field. Meticulous dissection of the posterior pillar and always preserve the mucosa. Always excise the supratonsillar fat pad, which can give you this good scar vector. Check off the palatopharyngeus if the palatopharyngeus is free enough to relocate. If not, you can release it more to clear tension. It is mandatory to enter with the needle in the same hole that the needle came out from the soft palate. Prevent extrusion. Make sure the suture is in the muscle layer and not in the mucosal layer. And from the raphe to the posterior pillar, a minimum of 3 loops. Do not buttonhole the mucosa medial to the posterior pillar. Cut the suture close to the surface mucosa and can put in some conventional sutures at the pillars if you want the tonsillar bed to be closed. These are few tips and tricks that would help you do the PRP. Next in lingual tonsillectomy with the halo wand. You can also see here that we are using the high setting, and that's where you're able to see that the posterior part is also getting ablated. The idea when we do a lingual tonsillectomy is to expose the entire valvula, and here we are using the halo wand with a 45-degree endoscope. Now, the halo wand works differently than the legend wands. This is more like a monopolar diathermy. This is from more of a touch technique, not the paintbrush technique that we all got used to with the C2 and the conventional. So, you can see on the tissue. Should be very, very careful to dissect laterally. See how the end procedure, you can see the plasma work. So we've done a tonsillectomy, I've done a Barb repositioning pharyngoplasty, and here we have done the lingual tonsillectomy. Once that is done, the distraction, osteogenesis, maxillary expansion, we put a cheek retractor, we give some infiltration there. The idea here is to create a midline sagittal split because this patient is quite old. We had to do, in order to do distraction osteogenesis, to increase the transverse dimensions of the soft palate. So now you can see that the anterior face, anterolateral face of the maxilla has been exposed. We are using a regular Fisher burr to create that leaf-out osteotomy. This is very different from the osteotomy that we do for the maxillary mandibular, that is the double jaw surgery. As you can see here, this whole thing is being done. This is fairly simple. Here, I would like to acknowledge our maxillofacial surgeon. This is Dr. Sukhwinder, who's helping us here. Here we're doing a midline sagittal split. And once we do that, we and then you can see how it's nicely sitting there. Now the whole same thing is done. And you can see how I'm using a Frears all the way back. Very anterior nasal spine. This is the vomer, as you can see. This is the maxillary crest. Endoscopic Fantastic. So now you can see the piriform aperture and how narrow it is, this patient's and the anterior spine as so now we're making this, we are cutting the sagittally. The, uh, it done endoscopically. You can also do a piriform plasty, that means widening of the piriform aperture at this point. This is for you to get an idea. This is the midline sagittal split. This is the piriform, and this is the Leafort 1 osteotomy. At the end, what started off like this becomes this. And you can see in the postoperative period, when we use a combined purely interdisciplinary approach, the AHI, which was about 31, has now come down to 3. And the flow limitations have also come back. What were 107 minutes spent hardly any time below 90%.